Professor Ineke Krasay. She's been involved in teaching and translation, in interpreting since 1991. She's written several textbooks on the area. She's won multiple awards for teaching, including Vice Chancellor's Teaching Awards in 2001 and 2012, and a Student Union Award in 2011. And just very recently, she got her professorship, and she is New Zealand's first Professor of Translation and Interpreting. So congratulations to you, Professor Ineke, and we are so very lucky to have you here today. Also, if you already don't know, she is the author of Introduction to Healthcare for Interpreters and Translators, which was released in 2013. This has been my bedside book for the last 5-6 years or so, ever since I discovered it when I was doing my studies in 2015. So if you haven't read this book yet, so you need to get your hands on it for sure. It is an amazing book. It's been translated into, adapted into Spanish, Chinese, Korean, Japanese, and Arabic. A Russian iteration is forthcoming, and a Turkish language iteration is in progress as well. Look, without further ado, you're not here to listen to me keep yapping on. I'm going to hand it over to Professor Ineke Krasay. Thank you, Professor.
Teşekkür ederim, Fatih. Thank you very much.
Thank you.
So we are here to talk about diabetes. And I am sure that you will have lots of interpreting or translation assignments which are to do with either diabetes or complications of diabetes, of which there are very many. And you might think that these are very difficult to remember, but actually they all make sense, and I will explain that to you. First, I'll just go very quickly through the 3 types of diabetes, and that's as per the Diabetes Australia website. Some people say there's only 2 types of diabetes. They don't count pregnancy diabetes, but Diabetes Australia does include pregnancy diabetes, which has got the difficult name of gestational diabetes. And there's lots of abbreviations, which I will introduce you to as well, if only because it's actually quite handy when you are doing note-taking to use those abbreviations. So the first type of diabetes is diabetes type 1. It's actually an autoimmune disease, and it's got both a genetic component, so it does run in families. So some people are predisposed towards developing it, but there is some environmental factor, and we're really not quite sure at the moment. Research is ongoing as to what that is, what triggers it to suddenly start appearing. Current thinking is that it might be a virus. Why are we not surprised in this year 2020, where we all really got to be very much experts on one particular virus? So the saying is, I wrote the old saying because I'm used to it by now, genetics loads the gun, but it's actually the environment which pulls the trigger. Sounds a bit like a Western, doesn't it? And so type 1 diabetes is also abbreviated as T1D. It used to only develop, or we used to only see it in young people, some children age 2 or 3 or 4, but now we actually see it in much, much older people as well. So there's a myth that it only develops in young people, but that is a myth. And I actually also have a link later on, again from the Diabetes Australia website, where they talk about some myths around diabetes. And there's lots of myths. So a type 1 diabetes requires very careful management because the pancreas, the body, doesn't make any insulin at all. And so these people with type 1 diabetes, they learn how to very carefully balance their need for glucose with their need for insulin, and they have to be very careful that they work out when to have insulin, how much, and then what to eat. And if they have a fever, their need for sugar is higher, and so they also need to take more insulin. A child that's growing will need more glucose, and so it will need more insulin. So it's a very careful balancing act. and it requires patients and their support people to have a really good understanding. Some children actually have an insulin pump, and there's a little picture there. There was a picture of a lady in a pair of jeans. I chose a picture of the young guy with a pair of jeans. Pretty much the same. You can see that there's one little contraption there which measures blood glucose level, blood sugar levels continuously. And then there is an insulin pump which then delivers insulin to go with that blood sugar level. So if the blood sugar level is high, you get a little bit more insulin, and we will explain more about, we'll look more at insulin later. So I've put a link there to the Diabetes Australia website about managing your diabetes technology, insulin pumps. They're actually not new. In fact, in the 1980s, when I was doing my training as a registered general and obstetric nurse, I worked with a lady who had diabetes since she was about 4 years old. By that stage, she was 35, and she was what we call a brittle diabetic. I don't know if that term is still used, but it just means that she found it very difficult to control her diabetes. This lady had one of the first prototype insulin pumps. And the funny thing, she didn't have a blood sugar measure contraption with it, but you could ask her at any stage, what do you think your blood sugar level is? And she would say 38. And then we would measure it and it would be 38. So she had a very finely tuned sense for what her blood sugar level actually was. That lady, because she'd had diabetes for so long and because it was difficult for her to control, she developed terrible nerve pains, also known as neuropathy, which I've got that word on the very last slide, I think. And that actually, this is a tragic story, it drove her nuts. The nerve pain was terrible, it was ongoing, it was excruciating. And so she actually ended up taking her own life, which is very, very sad. So it's a matter of trying to avoid all those complications, and there are many. They're all very similar, though. They have a similar pathway. 90% of all people in the world who have diabetes have type 2 diabetes, and we either abbreviate it as T2D or as T2DM. What does the M stand for? Well, you probably know as healthcare interpreters that when you get into being a healthcare interpreter, you actually have to learn 2 new languages. If you already speak Greek, that is a major advantage. I had the advantage of learning Greek at school for 5 years, even though it was reading Plato and Homer and philosophers, and I always wondered what the, aside from really liking Greek, what the use of Greek was. And then when I started doing nursing, I found that there's so many Greek words. So diabetes mellitus. Mellitus means something like sweet as honey. And diabetes means running through the body. So there's something running through the body that's sweet as honey. Why? Why call it that? Greek doctors were able to diagnose, another Greek word, diabetes. They would sniff people's skin and they would lick the urine. Oh, smells sweet. There must be sugar in there. Unfortunately, they couldn't cure it. It was actually not until about 1920 that insulin was discovered, 1920s, 1930s, accidentally actually, because some people with diabetes were injected with pancreas extract from dogs, and they were temporarily better. And then they were discharged from hospital. And of course, now we know you can't just give it once, you have to keep giving it. So that's sort of how insulin was discovered. So 90% of all people with diabetes have type 2 diabetes, and that number is going up. About 10% have type 1 diabetes, that number is also going up. So there must be some environmental factors, as I said before. So why do people get type 2 diabetes? There is no simple answer. It's actually very, very complex. Fatih and I were just talking, and I was saying how if you are stressed, and a lot of us are stressed, your cortisol levels go up. That's a stress hormone. And when your stress hormone goes up, your body gets ready to fight or to run away. And so it gets ready for energy use, and so your blood sugar level goes up. If you don't sleep, and very often you don't sleep when your cortisol level is up because your body thinks, whoa, I need to be awake, I need to be awake, I need to start fighting or running away. And so not getting enough sleep is also linked to high cortisol levels and high blood sugar levels. Some people say that you should definitely not have your mobile phone charging on your bedside table because that blue light may actually interfere with your sleep. So when you charge your phone, just take it out of your bedroom and put it somewhere else. Okay, so all these things seem to play a role, and there's lots of research studies being done. So this presentation is based on what we know at the moment. There's lots of studies being done. When I teach healthcare interpreting, I'm constantly updating my slides, and I'm reading a lot on different studies. Gestational diabetes. Now, this is actually something that I feel really quite sad about, because you will find that we will mention genetics. Some people say, oh, certain ethnic groups have more diabetes than others. To me, again, that's genetics. And the genetics often have to do with people being born to a mother who, unbeknownst to herself, very usually unbeknownst to her, had gestational diabetes. And we have to remember that it's actually only quite recently that people started testing for gestational diabetes in pregnancy, and usually between 24 and 28 weeks. And when women have gestational diabetes, even if it is managed, and we'll talk about more about that later, the chances that the children, offspring is the word used in research studies, their chances of developing type 2 diabetes and insulin resistance, and so reduced insulin sensitivity, are much higher. So there you are, you're born, you had nothing to do with it, your mother didn't know what was going on, and you already have an increased predisposition for type 2 diabetes and also for putting on weight. So some people call that fetal programming, which is a word I came across when I was doing research for this presentation. So in gestational diabetes, they test and they find that blood sugar levels are of people similar to people in pre-diabetes. Pre-diabetes means you don't quite have the blood sugar levels of someone with diabetes, but they are higher than normal. And midwives will immediately actually start, and obstetricians, doctors specialized in childbirth and pregnancy, they will immediately start treating. So there's a very clear animation which I've put there. Now, I promised Fatih that I would stop every couple of slides to see if there's any questions so far.
All good so far. Thank you very much, Professor.
Okay, so I shall go on to another thing that was actually mentioned. I did a presentation, a different one to this, but also on diabetes for universities and educators and students in Turkey. And in Turkey, there's quite a high number of people with obesity. About 57% of women are obese, and I think about 30% of men. The number of people with diabetes is about 12% of the population. If you think that's high, in the US, it's 50%. 50% of the population in the US have either diabetes or pre-diabetes, so they're heading there. But what I was actually told by my colleague there, Associate Professor Oktay Esa, he said, Enika, can you mention PCOS? Because PCOS is very common here. And there is an association between PCOS, polycystic ovarian syndrome, and diabetes, and it often gets treated with oral diabetes medication, metformin. It's very complex, so I will touch on that as well. So what are the settings where you might have to interpret for people with diabetes? There's actually a lot. And I have no doubt that this list that I've got here is completely incomplete, if there is such a thing. So I'd say the family doctors, because family doctors are often the first to keep an eye on people's health. And if people are complaining of feeling fatigued, lethargic, not having their normal energy, maybe they've got thrush, maybe they've got infections that won't heal. Those are all signs of undiagnosed diabetes. Maybe they're drinking an awful lot and they're peeing an awful lot. And because they're peeing an awful lot, they get thirsty, so they drink more. And if they drink fizzy drink, that's going to make the problem worse. And I'll get back to that later. So the GP might be the first to order some blood tests and to say, well, hey, your blood sugar is borderline high. I think you need to, I'll refer you to the diabetes educator or to the endocrinologist. Guess what? That's another Greek word. Endo means inside. You probably already knew that. Crine means to release, to separate. And logy is usually the study or the specialty of. So it's the specialty, the study of things that get released inside your body. What are they? They're hormones. So endocrinology is the study of hormones. Hormones we've actually got way more hormones than what we ever thought. And they're discovering new hormones all the time. I was reading about a new one just last week. And I think that was secreted inside your mouth, actually, by what we thought was a salivary gland. It's actually secreting a hormone. I'm not quite sure what it does. But hormones, basically, we are totally unaware of them most of the time, but they play a very important role in how we feel. And so the endocrinologist is the person that knows a lot about hormones. So not just diabetes, but also the thyroid hormone. Your thyroid gland sits here, looks like a little butterfly, and lots of other hormones, female, male hormones, all sorts. Dietitians, very important. Podiatrists, because people with diabetes can develop problems with their feet. And so they have to be very, very careful. They actually should not cut their own toenails. Neurology or cardiology or vascular specialists in blood vessels, because one of the complications of diabetes is actually damage to your blood vessels, and that causes a lot of other issues. Kidney failure can be a complication, so you might have to interpret in the dialysis ward, and physiotherapists, because once people have strokes, and a lot of people with diabetes do have strokes, then you will need a physiotherapist. So as you see, the list is very incomplete. Questions?
How about Australia and New Zealand within regards to the percentages of the population who have diabetes? Do we have that information?
I do have information about Australia. I didn't include New Zealand. In New Zealand, there are particular groups of the population which are much more likely to develop, say, for instance, gestational diabetes in New Zealand, and that often means that women are very likely to develop type 2. So I think for Pacific Island women in New Zealand, it's 18% of pregnant women get gestational diabetes, so pregnancy diabetes, but 15% of women from the Indian subcontinent, about 12% of Chinese women, and I think the European or Caucasian women are sitting on about 8%, so they're the least likely. It's totally unfair, and I was taking part in a project called TOFI, which means thin on the outside, on the inside, TOFI, and that involved Europeans and Chinese. And the Chinese would often look thin, so they would have a low BMI, which goes to show that BMI, body mass index, is not a very perfect measurement of risk, because Pacific Island people, for instance, they are often taller and they have more muscle mass. Maori people the same, more muscle mass than, say, for instance, people from the Indian subcontinent. And these Chinese women, would often have a lot of fat around their organs, but you couldn't really see it. I mean, they weren't tubby or anything. They just looked slim. And they often already had insulin resistance and pre-diabetes and borderline high blood sugar levels in their 20s. I have no idea why that is. I did talk to my students about gestational diabetes, and the Chinese students said, well, actually, we're always told it's great to have a big baby, so the mother should eat lots and lots of noodles and rice and dumplings. So I'm not sure if that's related, but the idea of eating for two in pregnancy is certainly not true. But you can see how culturally speaking, a big baby might be considered as healthy when in fact it's not. But I'll come back to that.
Just did a bit of research for the Australian numbers, and
Good on you.
according to the National Health Survey in 2018, the Australian Bureau of Statistics, 1.2 million Australians, so 4.9% of the total population, had diabetes in 2018.
Yeah, and that was a self-reporting survey, because I looked at that as well.
That's right.
And so that is very interesting, because New Zealand, we do the same thing. We do the health surveys. It's self-reporting. And the interesting thing is that people will always say that they're eating a lot of vegetables, doing a lot of exercise. And then when it comes to having their blood pressure done, blood pressure, and taking, a tape and putting around their waist to give their waist circumference, they are not very forthcoming. So self-reporting, I mean, it's good, but there is always the risk that people will give answers that they think are desirable. So I would say that that includes people who have a known diagnosis of diabetes, but there's a lot of people that are sort of heading towards diabetes and they wouldn't have the diagnosis as yet, so they probably wouldn't have said no. So yeah, I looked at that as well, and that was a health survey. So yeah, self-reporting, not always totally correct or accurate, but it's very difficult. So how many Australians? About 5% of the general population, which is what you just said. And I forgot to say that in some Pacific islands, like Nauru, I think, 50% of the population have diabetes. I think the same goes for Niue, which actually has a lot of quite thin-looking people. So as I said, you can't actually look at someone and go, oh, well, you've got such and such. You have to do all the tests. That's based on self-reported area data, and for some reason it is more common in remote areas than in central cities. Not sure why that is. It's twice as high in socioeconomically deprived areas. That's the same in New Zealand, and I will go into that a little bit later. But one of the things that we've noticed in New Zealand is that people in socioeconomically deprived areas, they often have to work two jobs. I always jokingly say, when you work two jobs, you don't have time to go home and toss a salad. You go for food that is tasty and it's readily available, and it seems to be good value for money, i.e. Golden Arches, KFC chicken. Chicken is perfectly fine, but they actually put a huge coating of carbs around it, sort of flour, which they made taste really lovely. It's delicious, but it doesn't actually give you a lot of nutrition. I work with a professor of nutrition, Elaine Rush, and she says that obesity is a form of malnutrition, because often people get there by drinking a lot of fizzy drink, eating takeaway food that's not actually very nutritious. And just watching this earlier this week, I was watching something about people eating, or rats, I think it was rats eating junk food, and they actually ate twice as much as rats that were fed a nutritious diet. So there's also something that seems to make you not feel that you've had enough to eat. Whereas if you eat food that's nutritionally satisfying and it's complete, you feel that you've had enough to eat more quickly, so you don't go on eating when you've already had enough, because your body's not signaling that. So there's a lot of stuff. Also, a lot of very poor areas are what we call food deserts. So there's no supermarkets where you can get fresh veggies or fresh fruit or healthy foods. Okay, diabetes higher in males than females. Increases with age. So I did the risk thing on the Diabetes Australia website. I scored really well, except I already got 6 points for my age. So it was quite disappointing, but it's nothing you can do about that. So doing everything right. Diabetes contributed to 11% of Australian deaths in 2018, and that's only if it was mentioned as a contributing factor or an underlying factor. And sometimes it is an underlying factor or contributing factor, but it's not mentioned as such on the death certificate. So you can see research is great, but you've always got to ask, how did they get the data? And is that a very sound methodology? So don't ever completely rely on research. Always try and look at lots of different studies. And remember, people find different things. I'll give you one example of that. My brother is a really well-known cancer researcher. He's got the same surname. You can look him up. And I remember 20 years ago, he said to me, don't eat broccoli, it gives you cancer. And then 5 years later, he said, eat broccoli, it protects you against cancer. Like, oh, wow, that's the complete opposite. So it just goes to show, you know, you get one study saying this, and sometimes you get a study saying the complete opposite. Is there any questions?
Does diabetes cause bad temper?
I think, well, this is interesting. I'll have to send you that little clip that I was watching. Somebody sent it to me the other day about food. And if you eat carbs, they had people eating carbs for breakfast or eating protein and I think protein-rich breakfast, no carbs or not many carbs. And they made them do a test where they could get angry. And the people who ate carbs for breakfast got way more angry. Again, you've got to look at the methodology. And then they repeated that with inmates in prison, that they gave the normal prison diet. Of course, these poor people, they can't go out to and buy their own lunch. We were just talking about that. They all have the same prison diet, and they supplemented it with, I think, supplements like fish oil, essential fatty acids, and all sorts of vitamins. And then the incidence, the aggressive incidence really dropped. So yes, some people say that, yeah, you could say based on that, that carbs make you aggressive, but I think it's also got to do with your personality and what else is going on in your life. And we all know there's lots of stresses. So I think one thing with research is that it's easy to say, okay, this leads to that, but all you can say really it could be a factor. Okay, Fatih, I'm waiting for you.
All
No,
good, all good,
yeah,
thank
all
you.
good. Okay, so yeah, you can tell I'm constantly reading things, but I have to. I always feel obliged to people in class to make sure that I at least have tried to read the latest, and it's impossible actually because there's so many medical studies published all the time. So why is diabetes such a problem? Well, to me, and I've looked after a lot of patients with diabetes, not only does it shorten people's lifespan, doesn't have to. My grandma was diagnosed with diabetes at 75 and she lived to 91. And yeah, so you could say, okay, that's one person who grew quite old. But it's like with the person, we all know one person who smoked all their life and they got to 97. And I always say that's a case study of one person, and they're the outlier. That means they're the exception. So a lot of people with diabetes suffer complications which really destroy their enjoyment of life, make them dependent on other people, and cause them a lot of stress and anxiety. In fact, stress and anxiety, I think, are seen in about 30% of people with diabetes. Don't know why that is. That's just a fact I'm throwing at you. So it can lead to complications which are not only disabling, but which really rob them of years of independent life, enjoyment of life. And just to mention some, Kidney failure is a big one. I remember working in Middlemore Hospital, which is a huge hospital in South Auckland. In 1992, 90% of people in the dialysis unit were about 42 years of age. They were mainly Maori Pacific, and they had kidney failure. They had end-stage kidney failure, so they were reliant on dialysis at 42. That is young. I'm older than 42. You probably guessed that. So kidney failure, you have to go on dialysis. You have to go to hospital 3 times a week for 4 hours and be attached to a machine for the rest of your life. And you feel quite rotten in between. Or you have to try and persuade someone to be a donor, but even then you have to be on immunodepressants. It can lead to blindness, all sorts of eye problems like cataracts, more likely in people with diabetes, glaucoma, retinopathy, which means that the nerve cells at the back of your eyes suffer because there's damage to the little blood vessels that supply them. And then there is heart attacks, strokes. Strokes a major cause of death in the general population, more likely in people with diabetes. And yeah, one of the worst things I think is limb amputations, and I'll touch on that later. If people with diabetes get COVID-19, they have more serious disease because in diabetes, your immune system doesn't work as well. And there's different reasons for that, and it's a complex story, but they're the ones that have more serious COVID. I thought it was people like me. I've got asthma and rheumatoid arthritis. Thank you, ancestors, for giving me all these lovely inherited autoimmune diseases. But actually, it turned out that people with asthma were not more likely to have serious disease. It was people with diabetes or pre-diabetes, which I think is partly why there's such high numbers in the United States and England, and also high mortality rates, because there's quite a lot of people with diabetes there. So, okay, underlying association. Yeah, I had that already. I think about the causes of death. So, diabetes type 2 in particular is increasing. It used to be definitely associated with age. So we'd see it in people age 40 plus, which sort of coincides with when people start to talk about their spare tire around their middle. So they're getting a little bit slower, a little bit more weight around the middle. And as you can see here, approximately 2 million Australians are at risk of developing type 2 diabetes. And it's one of the major consequences of what we call the obesity pandemic, which has really struck in the last 20 years. And I remember reading a novel by Alexander McCall Smith. He's the writer of the Ladies Number One Detective Agency and all sorts of other books. And he writes about Australian. He's Scottish. And he says that Australian men are wonderfully muscular and sporty until about age 26, when they just start to sit on the beach and drink beer. I don't, that's a gross exaggeration, but I found it quite funny. But of course, he's a writer, so he makes things up, doesn't he? So why are people getting more overweight? I think one of the reasons is that we live in an environment where junk food and all sorts of food that we probably shouldn't be eating too much of is readily available. It's advertised to children, and it's easy to get. We also, I mean, living back home in the Netherlands, I used to walk or cycle. In New Zealand, the distances are too great. So I put my bottom in a car and I drive. And straight after coming to New Zealand, I put on 2 kilos. I was probably a bit underweight when I got here, so it wasn't too bad, but it just goes to show we really have to make an effort to build activity into our day. I mean, who likes to run up 10 flights of stairs? I mean, most of us would rather take the lift, right? Probably better for us if we started walking those stairs. More sedentary work, most of us sit. Social distancing from the fridge, very difficult during a COVID-19 lockdown, as I'm sure a lot of you have noticed, and you're not the only one. I did too. And then genetics. So there's a higher risk of diabetes in some people, especially Chinese, South Asian, so Indian people, Korean people as well, Pacific Island people, Aboriginal people, Torres Strait Islanders, Maori, not Japanese for some reason. I think, I'm not sure why that is. They seem to walk everywhere and eat tiny, tiny portions. They eat everything, but they eat small portions. So portion control is another thing. And my Korean friend Amy said to me, we went to Seoul together because the book was published in Korean, and she said, wow, the little rice bowls, they used to be tiny like this, and now they're that big. They're twice or three times the size that you used to get in restaurants. And so that could be another reason. Fatih.
So far, so good. Thank you, Professor.
Okay. Okay, so I think to understand diabetes, we have to start at the beginning. And I have meticulously tried to put where I got all the images from, because I really believe in copyright and I want to acknowledge that. So all living things, including humans, need energy to function. And what do we do as humans? We breathe in oxygen and we eat food. And a lot of the food that we eat is carbohydrates, starches. That usually our staple diet. So in the Netherlands, it's bread. Okay, it's whole grain bread. So you could argue it's a little bit better and more nutritious for you than white bread or naan bread. For some people, it's rice. Some people eat basmati rice, which is arguably better for you than jasmine rice because it doesn't put your blood sugar level up so quickly. Some people eat noodles, pasta, tortillas, potatoes, French fries, you name it. Those are usually the staples. So we have that as the base of the meal and then other things with it. That's usually what happened. And that was okay when people were working really hard. So our ancestors, my grandparents, they were all farmers. They worked on the land. They were working very hard all day. And then they would eat 2 plates of potatoes, but they would burn that energy and they were lean. We still eat a lot, probably more than we need in terms of energy, but we don't use the energy. That's part of the problem. What happens when we eat carbohydrates, bread, rice, other staples? It gets converted into glucose in our body. Glucose is what our cells want for energy. So we breathe in oxygen, we eat food that gets converted to glucose, that goes into the cell, and the cell then uses that to produce energy, and in the process it also produces water and carbon dioxide, CO2, and we breathe that out. We breathe the water out as well. As you can tell when you breathe on a glass pane, you'll see it gets wet. So that's the water. Okay, so we get rid of it like that. So that's how we make energy. How long can you be without food? Most people would say 2 hours. The joke is always 3 weeks. Without water, 3 days. Without oxygen, 3 minutes. And then your brain cells will start to die off and your heart cells will start to die off as well. So what we love the most, food, is actually what we need, probably need least. Okay, so let's start at the beginning. So as we sit here, our body is made up of lots and lots and lots and lots of very specialized cells. We've got the skin cells, which is what you can see on the outside, and then every organ has got specialized cells. I won't go into that now. And all of those cells, especially our brain, need glucose and they need oxygen. So the bloodstream delivers the glucose to all our cells. So the bloodstream is very important that those motorways that we send the trucks with sugar along, that they are working properly and that they're wide enough and no traffic jams or blockages. But sugar, glucose, can only get into the cell if we also have insulin. The insulin attaches to an insulin receptor, and that then opens what I call the sugar door and what medical experts call the glucose transporters. Just sounds a bit like a science fiction movie if you ask me. So we need the insulin. Where does that come from? Oh, it's the same picture. So here we go. there's all the carbs that I mentioned. And then you can see the body converts those into glucose. Glucose is delivered to all the body cells. They're hanging out for it. The pancreas notices that and thinks, oh, okay, I better release some insulin. It's made in the pancreas. And the insulin also goes into the bloodstream and attaches to all the different insulin receptors. So far, so good. The sugar doors open and the sugar gets into the cell. And the cells are happy. Now, so to sum it up, a healthy body, see that strange looking organ? That's the pancreas. Then that's C-shaped red tube. That's the bloodstream. Of course, it's much bigger than that, but it's just a little picture. So sugar goes into the bloodstream. Pancreas releases insulin. The insulin attaches to the insulin receptors, and the sugar door opens. One of my colleagues, she was sitting in my class and she said, we don't need to know that. And I said, yes, you do. Okay, I'm different to a lot of, I suppose, linguists, and that I've got that health professional hat on too. You can't see it, it's invisible, but it's always there. So I feel that, yes, you need to know this. I quite like this picture of the cell with his napkin around his neck. Eating the oxygen, looks like a huge big sausage. Oh no, it's actually an oxygen bottle, and drinking a bottle of glucose. And I couldn't find that website again, so I'll have to try hard to find that. Questions?
I've got a few, but I think I'm going to wait till a little bit later.
Okay. Yeah, that's fine. So non-diabetes versus diabetes. In normal circumstances, pre-diabetes or non-diabetes, we eat the carbs. The glucose triggers the insulin response, so glucose, sugar goes into the bloodstream. The pancreas thinks, oops, some sugar there, and I need to release some insulin to make sure that that sugar goes into the cells. Now, just before I forget, normal circumstances, the body is really, really clever. So it will always maintain your blood sugar level at a certain level. You can't go below a certain level. And I remember being pregnant, feeling really faint, and asking a colleague to take my blood sugar. It was 3.8. I could have sworn it was about 2 or maybe even lower, but it won't, the body won't let it go lower. So I felt incredibly hungry and quite irritable because my blood sugar level was low. It's what we refer to as hangry. So there is this safety mechanism where your blood sugar normally won't go down below a certain level. Only if you help it along with insulin or oral diabetes medication can you reach a very, very low level of sugar, we call a hypo. Remember, it rhymes with low, hypo, low. Okay, so that's just a little memory aid. So normally insulin attaches to the body cells, to the receptors, and then the sugar doors open, sugar goes into the cell is happy, yay, got sugar. So normally blood glucose levels will be neither be too high or too low. But in people with diabetes, the pancreas does not produce insulin at all in diabetes type 1, because in diabetes type 1, the insulin-making cells in the pancreas are attacked and they're rendered useless, so that's the end of them. So it's an autoimmune disease where the body attacks itself. Auto means self. And in type 2, the pancreas doesn't produce enough insulin, and I'll talk more about how that starts to happen. And usually there's also insulin resistance because the insulin receptors have gotten worn out through overuse. You can imagine if you are constantly drinking sugar water, I call it, fizzy drinks, energy drinks, your pancreas is constantly having to pump out the insulin. The insulin receptors are just like a screw where you have loosened the screw with a screwdriver and then tightened it and then loosen it, tighten it, loosen it. And after a while, that screw needs to be replaced. The screwdriver can't actually attach to it properly anymore. This is more for the men in the audience, but I've noticed that as well. I don't do a lot of using of screwdrivers, but sometimes I do. So that's what it's like. So the receptors wear out, and so the insulin doesn't work, and the pancreas pumps out more insulin, thinks, wow, the blood sugar level's still high, let's release a bit more, and it gets exhausted, so it stops being able to produce so much insulin. So this actually happens over years, sometimes 8 to 10 years. So if untreated, what you notice is all the signs of sugar staying in the bloodstream because it just can't get into the cell. So we get the symptoms of high blood sugar level. And here we go, high and low. I wasn't sure where to put this slide, but I decided to put it here because last time I got a question about high and low. So the funny thing is that, well, it's actually not a funny thing. It's a sad thing. Both can lead to unconsciousness, confusion, and coma. Both of them. So with a high blood sugar level, and this is people who are developing diabetes, who are have pre-diabetes, so they're borderline high, they don't know it yet, they usually start to drink more than usual and they start to pee more than usual. And at this stage, I'm going to tell you a little story about a lady, I'll call her Alice, and she works in the hospital I trained in. She came in one night shift, and I was sitting in the nurse's station with a couple of colleagues, and we were all rather cowardly, as you will find out, except for one of my colleagues called Ronald. Right, so Alice comes in and she goes, oh my God, I've been so thirsty. And I sent my husband to the shops to get a 2.5-liter bottle of Sprite. I thought, yeah, that would be right. Sprite, my goodness. Anyway, and she goes, but I'm still so thirsty. I'm still so thirsty. So I'm just peeing all the time. And I'm drinking all the Sprite and I'm peeing all the time. And we were sitting there and I'm sure we were all thinking, oh my goodness. She must have very, very high blood sugar level, but she was rather angry. So I didn't want to say anything. And Ronald said, Alice, do you think we should check your blood sugar level? And she immediately was like, oh, because she realized. Because when it's you don't make that link. I'm sure if a patient had come in, because she was a very experienced nurse, she would have said, oh, high blood sugar level. So we checked her blood sugar level and the lab rang. And Ronald was putting a dressing on somebody's leg, I think, and a young doctor picked up the phone, and he picked up the phone and he said, who's this person that's got a blood sugar level of 38? 38. That is enormously high. She was actually heading towards ketoacidosis and a coma. So, yeah, she got diagnosed and she had type 1 diabetes, and she was in her late 30s. So it's the first time I realized we were being taught at that time, it's only young people, and I thought, wow. So it's not only young people. It can be a while before people get that. So I will never forget peeing and drinking more than usual. Okay,
Yes.
so you see all the high and low, and you see sometimes they're quite similar. So you see the weakness, the confusion, sweating, shakiness, and unfortunately with both of them you can get very confused. Now if you look on the low side, you can see an indication as to why the police would sometimes lock up people who actually had diabetes and who are having a low blood sugar crisis. Look at this, feeling hangry, irritable, angry, confused, clumsy, jerky movements, slurred speech, drowsy, confused. Sounds a bit like someone who's had too much alcohol. So I do know at least one story of a person who was locked in the cells overnight. That didn't end well. It became a real crisis. And before they realized that actually he was not drunk, he had a low blood sugar level. So it's very, very serious. Also, I remember looking after a girl in the hospital, a 21-year-old, who used to take her high dose of insulin, which she was supposed to take with her breakfast. She used to take that with her supper, which was just a few crackers with cheese. So at 1 o'clock in the morning, her blood sugar level would go right down, and we would try and resuscitate her. We would ring 3 bells, which means emergency, just like with a cardiac arrest, and we would resuscitate her, and she would always be swearing. I have never heard so many choice swear words, because with the low blood sugar, once she regained consciousness, she was still very irritable and moody, but we understood that. So I always say to interpreters, don't worry about interpreting anger. Health professionals are used to it. They understand it. They understand that people are angry, and we would rather that you interpreted the anger so we can be prepared for whatever comes after, and we understand. So don't worry, do not censor that anger, please. So contributing factors for a high blood sugar level: not using enough insulin, not taking enough oral medication like metformin, not injecting the insulin properly or using expired insulin, not following your diabetes eating plan, and they go together with your medication and your insulin. Having an illness or infection, because once you are ill, you actually need more energy. So you need to eat more and then also take more insulin. Those two go hand in hand. Can you see how important it is that people have a good understanding of how this works? Experiencing emotional stress, such as family conflict or workplace challenges, because your stress goes up, your cortisol levels go up, your blood sugar goes up, because you're getting ready for fight or flight, as they say. Okay, low blood sugar level. As I said before, the body's got a safety mechanism, so ours can't really drop too low. It can only drop low if you take insulin and then don't eat enough. So you take insulin and then you forget to eat your breakfast or something like that. Or you take your medication, but you don't have your breakfast. So your blood sugar level is going to be reduced down to below what it would normally go down to. Not eating enough, postponing or skipping a meal or snack, and you've had your insulin, so that's calculated in the fact that you were going to have that meal or that snack. So the insulin is going to take too much sugar out of your bloodstream, and it won't be replaced by your meal or your snack. Increasing your exercise or physical activity without eating more. You can see how that would happen. And drinking alcohol. And I don't quite know why that is. So please don't ask me that. I'll have to look that up. So back to insulin resistance, because it's such a common factor in people developing type 2 diabetes. And insulin resistance, unfortunately, sneaks up on us. If you're feeling great today and tomorrow you feel like rubbish, as they would say in the UK, you notice that and you go to the doctor and you say, look, I was great yesterday and today I'm feeling terrible. But if you start to feel gradually less well over a number of years, you don't notice that difference on a day-to-day basis. So it sneaks up on us. So insulin resistance normally is associated, okay, this is the most common way. There is different pathways, but mostly it's related to having too many carbs for what your body needs. I'm not talking about you being an Olympic athlete, an Australian football player, an NRL player, a soccer player, a long distance runner, or a triathlete, or somebody that's on their feet all day, every day doing manual work. I'm talking about most of us, and we wouldn't actually be that physically active. So let's say that I would be drinking, my favorite tipple would be, say, a fizzy drink or an energy drink. And who knows, a lot of people think that energy drinks are really necessary. I see a lot of IT people. I don't know if that's just my prejudice, but I see a lot of IT people with energy drinks, which is caffeine and sugar. And there's been studies that say that that's particularly bad combination, but let's leave that aside. There's a lot of sugar in fizzy drinks. There's a lot of sugar in fruit juice, and there's a lot of sugar in energy drinks. Because back in the 90s, I was listening to an endocrinologist who said, oh, people don't get diabetes from eating sugar. I mean, who can eat too much sugar? It's impossible. It makes you sick. But actually, people do drink a lot of fizzy drink and energy drink, and they just seem to, that doesn't make them sick. They actually have one glass after another, one bottle after another. There is a lot of sugar in that. Every time you have a lot of sugar, your pancreas has to pump out the insulin to deal with the sugar. And as I said, the insulin receptors can wear out. And so then the insulin doesn't go into your, doesn't attach, it's still floating around. The blood sugar is still floating around. So you have high blood sugar levels, high insulin levels. And we have never really got into the habit of measuring people's insulin levels. I'm not quite sure why. I'm reading a book about it at the moment, but both of those are not good for your blood vessels. They damage your arteries. High blood sugar levels lead to what we call advanced glycation end products, AGEs, and they do a lot of damage, but I think I've got that on a different slide. So most of the complications are actually related to the damage to our blood vessels. And what I haven't put here is that one of the pregnancy complications, which is preeclampsia or high blood pressure in pregnancy, is also seen more in women with prediabetes. So possibly already have damage to the blood vessels. They get pregnant. The placenta is not well established. Body is trying to get sugar and oxygen to the developing baby, but it can't because the blood vessels are not that great. So the body says, oh, well, then I'll just push the blood pressure up to make sure that that baby is getting what it needs. There's a lot of stuff that the pregnant mother's body does to look after the developing baby. And preeclampsia, unfortunately, can be a very dangerous condition. I used to look after mothers with preeclampsia, and it really scared me. Because sometimes it only goes away when the baby is born, and sometimes it happens too early for the baby to be able to be born, say at 20 weeks. I mean, the baby is not going to survive if it's born then. Okay, insulin resistance, again, a little picture. So you see the person that doesn't have insulin resistance, glucose goes into the bloodstream, the pancreas releases, that's the bottom left-hand corner, releases insulin, and then the sugar and the insulin, the insulin enables the sugar to be stored in organs such as the liver or the muscle, or I think in fat cells as well. And I've actually put a link in by a doctor who talks about 3 types of parking passes, and he calls insulin a parking pass. And he says you can get the parking pass for a muscle cell, parking pass for a fat cell, or a parking pass for a liver cell. So he explains it like that. Everybody's got their own favorite metaphors, if you like. Okay, so you can see in insulin resistance, the organs are unresponsive. This is also linked by some people to the amount of fat around the organs, which they say makes it very difficult for the insulin to get through. But anyway, it leads to an increased level of glucose in the blood. So eventually, with insulin resistance, the blood sugar level will go up. But I have to stress that for a long time, the body will keep compensating. And so your blood sugar level will look normal for a long time. Does that make sense? Because the body is compensating. It's just like with the thyroid. They used to just check thyroid function. They would check your thyroid hormone, T3, T4. Oh, normal level. But now they have started looking at the thyroid stimulating hormone, which is released by your brain. And I noticed in some people, this was normal, but that was really high, which meant that so much kicking of the thyroid was taking place to try and produce that normal level of thyroid hormone. So now they really look at the thyroid stimulating hormone. And if that's low and this is normal, that means the thyroid has no issues at all. It's like a horse that's just galloping along normally without being like horses at the Melbourne Cup, being whipped and whipped and whipped by the thyroid stimulating hormone. And it's the same with your blood sugar levels. Are they normal because everything is working really well and it's all happening very quickly? Or is there actually a lot of trouble behind the scenes with the pancreas working overtime to produce enough insulin to make sure that that blood sugar level stays the same? And so I suppose that's why they started doing the oral glucose tolerance test, where they give you a little cup of something sugary, and then they keep taking your blood sugar level. And they also do that when they test, for instance, a new bar. In my university, there was a new bar which was supposed to be low glycemic index, so increasing your blood sugar level gradually. And I was one of the volunteers, so I had no fingertips left. So I would eat the bar, and then they would keep taking my blood sugar level with the finger prick, every half an hour to see how quickly my blood sugar level went up and how quickly it went down. I'm not sure I was a very good test subject because it went down very quickly. Because lucky for me, I don't have any diabetes in the family. So that's how they test. And then I had to come back 2 weeks later and I had to drink a little thing of sugar water, and they did the same thing. So that's a glucose tolerance test. They load you up with water, with sugar water, and then they test how quickly your blood sugar level goes up and then down. And for the TOFI study, thin on the outside, fat on the inside, they gave me sugar through one arm, through an IV, and then tested my blood sugar level at the other arm. So again, to see how quickly my body was dealing with that. So those are all ways of testing how efficient your body is actually working. Okay, so as you can see here, high carb diet. Carb stands for carbohydrate. So all those different foods that get converted into sugar. Pancreas keeps releasing insulin. So we get high levels of insulin in the blood, overuse of the insulin receptors, they wear out, and also the pancreas gets really sick and tired of producing all that insulin. So eventually the system's going to give, and we're going to have high blood sugar levels because it's just not working anymore. But that takes some time. It can take, as I said, 8 to 10 years. And I've seen longer time periods in some studies. So I've put in some animations. And as I said, for those of you who like stories about cars and parking lots, there's one doctor who likes to explain it like that. I don't know, you may have a lot of car-loving patients. And then there's a very clear clip on AGEs. Sounds like something very nice, but it's actually advanced glycation end products, and they are responsible for many of the complications of diabetes. So just to sum it up, and then we'll have time for some questions. The factors, so it's not cause effect, A and then B. Now these are all things that play a role or can play a role. Age. So as I said, you can do the risk. What is my risk? I've put that link in as well, which I think is quite fun. And I did all the questions, lots of exercise, lots of vegetables. So I did so well on what I could control, but my age was against me. So I already got points against me for age, and that's something they can't do anything about. Then I did some other people that I know who've got relatives with diabetes, who've got high blood pressure, and they scored quite high. So they have to watch it. So I think it's just a matter of awareness. What is my actual risk? And remember, I always say to my students, it's like life and your body is like playing a hand of cards. People deal you a hand of cards and you look at them and you think, oh no, that's not very good. Okay, so I got asthma, rheumatoid arthritis, psoriasis, not too bad, and lots and lots of heart disease in the family. So those are my cards, okay? But I play a good game of cards. So I'm playing them really well. And then some people get really good cards and they think, oh, well, they're made of, they're bulletproof and they just live a life. And you think, oh my goodness, what are you doing? You had such good cards and now you're not playing a very good game. So there's a lot of things that you can control and that you can do. So genetics, big role, as I said, can't do much about that. I think a high carb diet, look at it. And there's an app, a free app called Carb Manager. I didn't put it in the slides, but I found that very, very useful you can search foods, you can scan them, and you can see how many carbs are actually in there. Okay, physical activity, you can build it into your day. The environment and the food manufacturers, they've cottoned on to the fact that sugar is addictive. It hits the reward center in the brain, makes us feel good. So we have sugar, blood sugar goes up, blood sugar goes down, we want more. Blood sugar goes up, blood sugar goes down, we want more. It's very addictive. So they even put in things like tomato ketchup, tomato soup. I had a look at a whole lot of things in my pantry the other day, and I thought, wow, it's sugar in lots of things. Okay, and then if your mum had diabetes while she was pregnant with you, and they say on the website of Diabetes Australia that about 58% of type 2 diabetes can possibly be prevented. But if you look at that TED talk by Dr. Sarah Hallberg, she says that type 2 diabetes can be reversed if you go on a keto diet. Keto diet, high fat, moderate protein, and really, really low carbs. Again, talk to your doctor first, but have a look at it. It's quite interesting.
Thank
So,
you.
family history, age, over 45 and overweight, over 45 and high blood pressure, over 35 and either of Aboriginal or Torres Strait Islander background, over 35 and either Pacific Island, Indian subcontinent, or Chinese. I don't know why it says cultural background. Again, that is genetics. And if you're a woman who has given birth to a child that weighed more than 4.5 kilos, or had gestational diabetes, or had polycystic ovarian syndrome. Having said that, I had a student with polycystic ovarian syndrome. I was mentioning it in a lecture. She came back the week after and said, wow, I went to the doctor and I've got that. And she lost weight and it went. But I've seen her again recently and she said she now has type 2 diabetes. And this is actually 20 years on. So it's taken a while. So check your risk. That's a very interesting website. And again, as I said, questions 6 to 11, those are factors that can contribute. So obesity, I've mentioned all of this. Remember, fruit juices and dried fruit, they are full of sugar. If you wouldn't eat 4 oranges, but to get a good glass of orange juice, you'd probably squeeze 4 oranges. So, and you don't feel full when you drink a glass of orange juice. You feel full when you eat 4 oranges. So a lot of people say better to eat the fruit than to squeeze it and drink it because you don't know how much you're getting. A lot of people don't really understand what food is doing with their bodies. There's a lot of cultural factors. So I know a lot of Chinese people say to me, no, I won't stop eating jasmine rice. I love it. It's so fragrant. And I've got a Korean friend who said, yep, I did. I love it too, but not good for me. And I've got borderline high blood sugar levels. So no, that's it. I'm eating kumara now. That's a starchy vegetable. It's like sweet potato, but she's totally stopped eating rice. So obesity is often linked to metabolic syndrome, and that's a difficult word, and it means a cluster of fat around the stomach, high blood pressure, high blood sugar, high serum triglycerides, which go up when you eat lollies and sweets, and low serum high density lipoprotein. HDL is the lipoprotein that takes all the cholesterol out of your blood vessels and brings it back to the liver. So that's associated with cardiovascular disease. I think you need to start with looking at how many carbs you're actually having, if it's you yourself. Interesting, Diabetes UK have a low carb program, but I couldn't see it on the Diabetes Australia website. So go there, that's a link you can click on. And you see, so even different national associations have different ideas, and it can often be just some very vocal, respected people that decide what goes on there. The website of Diabetes Australia is really, really, really good. It's extensive. It's got something for everything. I think they're constantly updating it and working on it. Low carb program. As far as I can see, I mean, it could be on there tomorrow. Who knows? So always speak to your doctor first. So look at the very low carbohydrate. That's what I'm trying at the moment. I tell you, it's really difficult. I'm having 20 grams of carbs a day. It means I can't even have a cappuccino because it's already 19 grams of carbs. It's crazy. My favorite, yogurt, full of sugar. Without sugar, but it's got lactose in it. So have a look at the TED Talk. I don't have a lot of time for gestational diabetes, but here's all the risk factors. And unfortunately, with gestational diabetes, there is a real risk of medical complications and even of problems with the baby. That's why the midwives and the obstetricians are really onto this, and they really watch these people, these women, very, very carefully. So that's the good thing. We've got a good public healthcare system in both Australia and New Zealand, and we are being looked after very well. So have a look at all the short-term complications. So it's linked to high blood pressure. For the baby, it's linked to being really big, macrosomia, large for gestational age, higher body fat, and after birth, also putting on fat more easily, being insulin resistant, and being more likely to develop type 2 diabetes. Labor will be longer with a big baby, very often cesarean birth, can be surgical complication, can be a longer hospital stay. Baby may end up in the neonatal intensive care unit, even though it's very big, because it's not that healthy. The mother may bleed after birth, and there may be more chances of infection. And as you can see with the long-term complication, they are that both mother and child may develop type 2 diabetes, may have cardiovascular disease, so problems with your heart and blood vessels, may develop metabolic syndrome, which I've just talked about, and may put on too much weight. So PCOS, I won't mention now. I'm going to skip that. Myths and facts, very important, very interesting. Patti.
There was a question about PCOS, if you could just quickly touch on that one.
Yes. Okay. We used to think that it was just women with an apple-shaped body who had acne, breakouts, hair, especially in the neck, but it's actually completely untrue. You can't tell by looking at a person whether they've got PCOS or not. You need to do blood tests, and there seems to be two main types of people that develop PCOS, but there's actually a lot of different factors. Again, it's not just cause effect, very simple. For instance, people with PCOS are, I think, 3 times more likely to develop something called Hashimoto's disease, which is to do with your thyroid. Some women with PCOS, when they were treated for their thyroid problems, absolutely had no more PCOS symptoms. These are just some things that I've read recently, and I put some links there. So some women with PCOS put on fat very easily. So they've given them the strange name, the heavy type, and Dr. Brooke quite rightly says, no, don't like that. Heavy type, lean type. Please, there is enough trolling and giving people names. Don't like it, let's stop doing that. The fat resistant type of PCOS, you don't actually put fat on as easily, so people look lean and they have different issues, but all of them have insulin resistance. So that's the one that's in common, and very often is treated with metformin, which is an oral medication for diabetes. Okay, Fatih?
Yep.
Is that enough? Because I just want to show you some horrible photos. So this is the keto diet. So have a look at that. Now, possible complications, very easy to remember. It's all to do with damage to blood vessels, big and small. Small in your eyes, big going to the brain, and then smaller blood vessels in the brain, the heart. All of these, if they're damaged and narrowed, you can get problems with the blood supply. The worst one is the one in the feet, and I really didn't want to put a photo up of that. So with eyesight, you might be interpreting for people with cataracts or glaucoma, retinopathy, which means that the nerves at the back of the eye are affected. People may have blurry vision, it's very common, or floaters. Now, I even had some floaters a couple of months ago. I thought, whoa, what's this? It's like I kept taking my glasses off and wiping them, And the floaters were still there because they weren't on my glasses. They were actually inside my eye. So the glaucoma, I've put a little picture on. And cataract, very common in people with diabetes. Stroke, this was my first ward when I did nursing training, was neurology. And we had, I remember saying, wow, we're constantly changing people's bed sheets. They're so sweaty. And one of the nurses said to me, of course they're sweaty. They've got diabetes. What were you thinking? And I thought, what? I was just starting. So I had no idea about diabetes and sweating when your blood sugar drops low, and then being more likely to have a stroke because your arteries may be damaged. So just to show how many arteries are in the brain, I found this little picture, and you can see a blood clot there. But sometimes the blood clot is actually in these arteries, which are called the carotid arteries. Same word as carrot, by the way, like a root. It's a root vegetable, carrot. The carrot arteries, we could call them from now on. All right, and then of course with a stroke, you get these classic symptoms, and I've put the Australian emergency number on there. For us, it's 111. Okay, so face, arms, if they can't lift their arms up, speech can be slurred, understanding can be terrible. Pick up the phone, because if you're very quick, the clot can actually be retrieved.
As we were saying earlier, that's why, because it impacts so much of your body, that's why we are working in so many different settings. You know, we could
Exactly. Yeah.
we could be working at the eye and ear hospital, we could be working with a cardiologist, a dietitian, a physiotherapist, even an OT for someone who's had an amputation, perhaps,
Yeah.
right?
Exactly.
So we can see how it all fits together now.
Yeah, speech and language therapist. So there's all these different, and so with the heart attack, this is very interesting. This picture, you see the women. Women can have totally different symptoms of heart attacks. And it's taken doctors years to realize, whoa, you'd think this was obvious. Women's bodies are actually very different to men's bodies in a lot of different ways, not just the obvious ways. So women with heart attacks may actually just feel nauseous, indigestion, and that may go on for a number of days, and they may think, oh, well, I've just eaten something wrong. They may just have heartburn, flu-like symptoms, and it's actually a heart attack. So they may have all the classic male symptoms, but they may not. So don't be surprised if those questions are asked. And of course, chest pain can go up, can radiate into the jaws, can be in the arms, can just be in the arms, sometimes just in the wrist area. So there's so many different manifestations. People are unique and they are different. Shortness of breath tends to be quite common in all of them, and a sense of impending doom. And here's just a coronary artery, it goes to the heart. So you can imagine if somebody has a heart attack, the part of the heart that's affected, those cells will die off. So don't ask me why, but our most important parts of the body, the brain and the heart, once those cells die off, they don't come back. It's like, okay, game over, I'm out. Stand on the sideline, not participating anymore. And that's our most important part. So here's some possible tests. Coronary angiogram, you may have to interpret for that, and you must ask for the lead apron, the lead collar, and the lead body. Oh gosh, I can't think of the word now, because all your important glands must be protected from radiation. So don't go in without your protection. Ask for it. You are important. I have heard stories where interpreters didn't get fitted with their protective
Wow.
shirt. Yeah, maybe not in Australia, but yeah, it's definitely happened. So possible treatments, put those in. Kidney failure, as I said, it is so common in people with diabetes and so dreadful because you really can't be without your kidneys. My grandma died of kidney failure at age 30. She didn't have diabetes. She had another autoimmune disease that luckily I didn't inherit in my hand of cards. That was lucky because that was a really dreadful one. But here's the main three options in New Zealand. Peritoneal dialysis is still common. It's really not effective and the lifespan is quite limited. Interestingly, with informed consent, usually it's not said. And I think that's wrong. Not much we can do as interpreters. Hemodialysis is way more effective, way more efficient, and kidney transplant also way more efficient, even though you have to be on those immune depressant drugs for the rest of your life, as long as your donor kidney lasts. They usually leave your own kidneys in and they just implant the donor kidney lower down. So here's
Just
the two. Yeah,
sorry, Professor, just within
that's
regards
okay.
to possible treatments, there was a question asked earlier within regards to alternative medicine. Are you aware
Yes,
of any alternative medicine that may help, or
diabetes,
non-Western treatment? Yeah.
not well, non-Western. Um, Not in terms of Chinese medicine that I know of, but I'll have to check with friends who are really good at, really at home with traditional Chinese medicine or TCM. I've got another friend who is a big proponent of Iranian traditional medicine, which actually interestingly was also hot and cold, a lot to do with the foods. I would say the non-traditional one at the moment, which I hope will become more mainstream, is the um, let's just not eat carbs. Um, now, the Dr. Hallberg says we don't actually need carbs. Why are we making people sick by saying, okay, you need to have 50 grams of carbs with each meal, and then take something to lower the carb and take it out of your bloodstream? She says, why? Why are we giving carbs and then treating the problem that we've just created? So she's actually talks about a whole lot of people with type 2 diabetes that she was looking after who now no longer have signs and symptoms of type 2 diabetes. So that would be the only direction I could point you at for that.
Thank you.
And it's not mainstream yet, but I think it's an interesting thing to explore. I think I'm almost at the last, so you might have to interpret for a nephrologist, that's a kidney specialist, dialysis staff, dietitian, because even with hemo dialysis and peritoneal dialysis, people have to be very, very careful, particularly with fluid. I mean, they can't have that much fluid a day. It's for 500 mil fluid limit, and 500 mils really isn't an awful lot. I think that's about 500 mils. So
It's a
that's all
small
they can
water
have
bottle.
over a tiny water bottle and tiny glasses, tiny cups. So you feel like you're having a cup, but it's more
Little
like
sips.
little sips. That's right. Mindful drinking and eating. And yeah, this is the most awful one. Takes forever if you're interpreting for people with peripheral vascular disease. So it's the blood supply into the legs and particularly into the feet. And you will hear people say to people with diabetes, please always wear your sturdy slippers when you go to the toilet at night. Because, first of all, there's nerve damage. So when people go to the toilet at night, it's dark, they don't want to turn the light on, they don't want to wake their spouse. They knock their toe against something. I don't know about you, I'm always knocking into things accidentally. They knock their toe, they don't feel it. So there's damage, there's reduced blood supply, it doesn't heal. And to be honest with you, I didn't want to put those photos up, but I have seen people's toes that looked like this. And this is my lipstick, so don't worry, it's not an amputated toe. They looked like that, they were black. And they were saying to me, nurse, will my toes get better? And I'm thinking, it's necrosis. And that's the Greek word for dead tissue. It smells because it's dead. And very often they will then feel for the pedal pulse. I think I put that in my glossary. So that's the pulse, the artery on top of the foot. So if this is my foot, you'd feel it here. They normally put a cross there. So they use a marker pen. They put a cross there so that other staff know this is where Nurse Jenny, okay, Boris Johnson, Nurse Jenny, this is where she was able to feel the pedal pulse. That's how bad the blood supply is. So sometimes, unfortunately, they have to say, look, we're going to have to amputate this because it's not going to get better. And if we leave that leg on, it's just going to be bad for the body as a whole. So they do a below the knee amputation. So it's yeah, take it seriously. Try and avoid it. Have a look and see what you eat every day, how much energy you expend. You really don't want to get this. And I think you really need to understand the mechanisms if you want to be interpreting in those settings. So yeah, again, so my approach to healthcare interpreter education is actually a sort of nursing 101. I think interpreters need to know how the body works, how it's put together, that's called anatomy, how the body works, physiology, what can go wrong, that's pathology, most commonly asked questions. And once you know those three things, you will understand the most commonly asked questions, why people are asking that, and you also understand the treatments. Medicine is racing ahead. We saw that this year with the what we're calling the vaccine, the 2 vaccines that were developed, which are actually targeted therapy along the immunotherapy treatment for cancer cells. So very interesting new biochem approaches. So try and keep up with the changes. It's difficult, but it's important. And Australia is actually quite advanced, quite pragmatic. So they and people and doctors in Australia take on the new findings very quickly. New Zealand is a little bit slower sometimes. Less population, less tax, less money, maybe, I don't know, but yeah. So it's good to keep up with the field that you're interpreting in.
Professor Enike, thank you so much for your amazing delivery and presentation today.
You're very welcome. It was my pleasure.